We shall now go on to Dr. Prem Subramanian, and you're truly lucky to have him amidst us today, an individual of brilliance and standing. He's a vice chair for academic affairs and heading the Neuro department at the UC Health Eye Center in Aurora, Colorado. He holds joint appointments in neurology and neurosurgery and is the president-elect of North American Neuro-Ophthalmic Society. He's going to be giving the keynote address, and he's going to be detailing on understanding supranuclear disorders and of ocular motility.
Good evening, and thank you very much. And thank you, Dr. Arul, for kindly allowing me to go ahead, and Dr. Chitha for the invitation. So I'll be speaking about supranuclear gaze control and disorders involved in that. And this is a topic that has been introduced in part by some of the other speakers. And I'll start with a case presentation of a 68-year-old woman who collapsed at home. We saw her, she was transported to the emergency department, and a CT of her head showed a subarachnoid hemorrhage. She had a ruptured giant basilar aneurysm, so an arterial aneurysm affecting the brainstem, and she had emergent surgical clipping. And she was in coma for 3 weeks afterward. She recovered, and about 3 weeks later awoke with double vision. It was horizontal, it was present at all distances and constant, and she was unable to look up or down, and she also had mild imbalance. So I don't have a video of her, but I have some videos I will show you later. Her afferent visual function was completely normal. Pupils normal, equal, extraocular movements were full, but she had absolutely no elevation or depression of either eye. She had full horizontal ductions, absolutely normal, and she had a very large angle exotropia. So in trying to localize where a patient like this has a problem, so a big exodeviation, inability to look up or down, and normal vision, and as well as some other neurological functions. Could this be a bilateral partial third nerve palsy? Well, as you heard, you should not have preservation of adduction if that occurs, and there was no pupil involvement, and she had no ptosis, so that didn't make any sense. It could be an orbital process, of course, but that did not fit with the history. You could do forced ductions if you were really suspicious of that. But among the other things you already heard from the other speakers about testing motility and testing for various ocular motor disturbances, what you should look for is you should look for saccades and pursuits. Can the patient initiate movements to the right or left or up or down? Do they initiate them quickly or are they slowly? And do they overshoot? Are they hypermetric? Or do they undershoot? Are they hypometric? And once they make the saccade, do they have difficulty holding the eye in that position of gaze? Similarly, with pursuit testing, both horizontal and vertical, a small target, move it slowly back and forth to truly test pursuit and not exceed the retinal slip velocity. Is the pursuit saccadic or is it smooth? Do they make little steps? And I'll show you some examples of this. Remember that the OKN drum is a nice way of testing pursuit as long as you don't rotate the drum too rapidly. So when we think of disorders of gaze, supranuclear disorders of gaze, the problem is generally going to lie in one of three places. It's going to be in the cerebellum, in the brainstem, or it's going to be cortical. Now, the cortical problems tend to be very acute and resolve quickly, and so what we'll talk about is primarily cerebellar and brainstem problems. So for the postgraduates, remember that you have frontal eye fields in the frontal lobes, you have the parietal or posterior eye fields as well. Both of these actually inhibit the action of the brainstem centers. So this is why damage in some of these areas can lead to overaction of the extraocular muscles, hypermetria. So that's your big clue often, is when the patient's eyes are moving too much, that suggests a supranuclear disorder, whereas nuclear or infranuclear disorders result in decreased movements of the eyes. Just a general rule that is helpful. The control of vertical eye movements is here in the midbrain, and control of horizontal eye movements typically arises from the pons. Dr. Rushman mentioned the PPRF, the parapontine reticular formation, which then has input to the sixth nerve nuclei, and I will show you how dysfunction of the PPRF leads to horizontal eye movement abnormalities. We'll start though with the vertical gaze centers, which are a little more complicated. You have the rostral interstitial nucleus and the medial longitudinal fasciculus, and they communicate with each other through the posterior commissure. Part of it, the lateral part, is probably responsible for up gaze, whereas the medial part may be responsible for down gaze. And this drawing does not really reflect the fact that the medial part may not communicate through the posterior commissure, but the upper parts do. So a lesion unilaterally of the RIMLF may lead to a total up gaze palsy, while you need to get both RIMLFs on both sides in order to end up with a down gaze palsy from supranuclear disorders. There is always going to be input from the vestibular nuclei as well, influenced by the cochlea. So don't forget about that as well. This is the basis of abnormal gaze in the setting of vestibular dysfunction. So we'll work our way from the bottom of the brainstem up but work our way back to the pons as well. So I'll start with a medullary dysfunction that you will classically see, the Wallenberg syndrome with lateral medullary infarction. Non-ophthalmic symptoms include ipsilateral pain or temperature sensation impairment, a central Horner syndrome. You heard a beautiful talk on Horner syndrome. This is a first-order neuron problem that causes it on the side of the lesion. They may have limb ataxia and bulbar dysarthria or dysphagia. But what do we see as ophthalmologists? We may see that in the setting of vertigo, they may have nystagmus, but they may report a shift of the visual vertical. They may tell you the room is tilted or the room is even upside down. This is characteristic of Wallenberg syndrome. They may also show lateropulsion, a sense that the eye or body is being pushed toward the side of their lesion. And they have hypermetric saccades on the side of the lesion, hypometric sides away from it. And they may show an elliptical trajectory of their saccades. And this gentleman demonstrates that very nicely. Watch as he looks up and down. See, and he's trying to look straight up and down, but his eyes deviate to the left side as he looks down. And this is classic ocular lateropulsion. He's not trying to do this. This is involuntary deviation of his eyes toward the left side as he is making what he thinks are purely vertical saccades. So if you ever see this, look carefully for Horner syndrome, look for vertigo, ask the patient about vertical shifts in their perception of the world. Similarly, the ocular tilt reaction, I mentioned that can be part of the Wallenberg syndrome. What is this ocular tilt reaction? It is a manifestation of an abnormality in the otolithic optic pathways, so that cochlea is having output to the vestibular nuclei, and if your balance sense is off or the balance system is disturbed, there can be an abnormal response where the eyes do not tilt properly. Showing you an example of this. When we tilt our heads, there is normally a righting reaction where the eyes come back to the vertical so that the world does not look tilted to you. And that is shown here as this physiologic leftward ocular tilt reaction. The eyes are tilting back to the vertical when the patient tilts his head to the right. But in this patient who has an abnormality, when he tilts his head to the left, the eyes are not able to rotate back center, and in fact, either rotate farther toward the left, or they just stay closer to the vertical, but they're actually pathologically going to the left instead of rotating to the right, like they should. And what happens then? Your brain tries to compensate, and that attempted correction is what results in a vertical misalignment. This is a very complex subject. I don't have time to explain it in detail, and I recommend to all of you that you read the excellent papers by Michael Brodsky, my colleague at the Mayo Clinic, who has written beautifully on this. But some things you can remember: skew deviation shows that the lower eye is on the side of the lesion. So you have a vertical strabismus, but the lower eye is actually on the pathologic side. It may be comitant or incomitant, and it may mimic a paralytic strabismus, but it is a supranuclear disturbance of gaze. So again, you heard a beautiful talk from Dr. Digvijay about fourth nerve palsy. How can you differentiate a skew deviation from a fourth nerve palsy? It can mimic it because the patient may have a head tilt and head turn, just like in fourth nerve, but the torsion is different. The higher eye will be encyclotorted versus excyclotorted, as you will see in fourth nerve palsy. But that torsion may be hard to determine, and the patient may have trouble expressing that, or they may not have limited torsion. So there has been a fourth step of the Parks-Bielschowski third step test that has been suggested. And that third step, or that fourth step, sorry, is after you do the primary right and left and head tilts, you lay the patient supine. So this upright supine test, which is done where you think the patient may have a fourth nerve palsy, if you get a 50% or greater decrease in the vertical deviation, as shown in this graph on the right, that is much more characteristic of skew deviation than it is of a fourth nerve palsy or other causes of a vertical strabismus. So remember that when you see a patient who may have fourth nerve palsy, but maybe the history doesn't fit, or they may have some other neurological problems, tilt the chair back, remeasure the deviation. You can have them look at a spot on the ceiling, and that can help you to differentiate these things clinically, and tells you that patients with skew deviation need an MRI of the brain with gadolinium to look for stroke, tumors, or other potential causes of that skew deviation. We'll move now to midbrain lesions. The classic midbrain lesion causing a supranuclear gaze disturbance is the dorsal midbrain syndrome. Compression of the posterior commissure. Remember, I told you that the RIMLF communicate with each other through the posterior commissure. The compression by a dorsal midbrain tumor or a pineal tumor leads to a combination of a paresis of up gaze, producing the so-called convergence retraction nystagmus, along with pupillary dysfunction, light near dissociation, eyelid retraction. Oculocephalic maneuvers are preserved, though. So this was a teenager who presented with a pineal tumor. You can see that her horizontal gaze is completely normal. Now, when she tries to look up, she develops the convergence retraction nystagmus. You can see that her eyes are coming in toward the nose. They are not going up, even though she is trying to look up. So this is the classic convergence retraction nystagmus at upgaze paresis with attempted voluntary upgaze. But now, when I move her head, I can overcome that upgaze paresis, and her eyes move completely normally. This is what tells you again that this is supranuclear. The nuclei themselves are working just fine. I will skip over the pupillary findings. You had a lovely talk on pupil disorders already. Other midbrain lesions can give you nuclear or supranuclear disorders that produce paresis of vertical gaze. It may occur after infarction, after tumor compression, and upgaze, downgaze, or both may be affected. So unlike the dorsal midbrain syndrome that I just showed you that has the classic triad of findings, here you may see an isolated vertical gaze disorder. So this is an example of a patient who had a stroke, as I will show you, in the unilateral RIMLF. And you can see that this patient has completely normal horizontal eye movements as seen on the left, but on the right, he has a complete inability to look up or down. And this is caused by a lesion here. So this is an MRI of the midbrain. And on the right side of the midbrain, there is an infarction. This is structural, and this is DWI imaging showing restricted diffusion and an acute stroke in the RIMLF, leading to an upgaze and downgaze palsy in this patient. And this is just histology correlating that lesion in the RIMLF with the gaze paresis. I'm going to skip over this video in the interest of time and move on to supranuclear palsy. Progressive supranuclear palsy, a disorder you should be familiar with as an ophthalmologist, presents with deficits of vertical gaze, more often down gaze than up gaze. It may be the presenting or early symptom. Patients then go on to have difficulty with speech, motor control, and swallowing. And it is a difficulty with swallowing that unfortunately leads to aspiration pneumonia and frequently death within 6 years of onset of the disease. Treatment is not yet very effective, but these patients will have characteristic ocular motor signs: square wave jerks, saccadic VOR suppression, slow and hypometric horizontal saccades, and very slow vertical saccades. And I will show you some brief examples of these. So these are the square wave jerks, these little horizontal eye movements off target that affect these patients. Here you can see that they have a saccadic OKN. The patient is being turned around for a VOR and it does not work well. Here they have slow horizontal saccades, and here you can appreciate that they now have very slow upward saccades. See how long it takes them to initiate once they're told to move their eyes? It's just very, very slow. This patient is paying attention, he just can't move his eyes well. And then finally, very poor down gaze. This constellation of findings, highly characteristic of progressive supranuclear palsy. Finally, we can see that with disturbances in the pons of the PPRF and horizontal gaze centers, we can see a complete deficit of horizontal saccades. I will show you a patient with a complete horizontal gaze palsy. This is different from a nuclear sixth nerve palsy, because there you end up with a complete gaze palsy that cannot be overcome by vestibular movements or by oculocephalic maneuvers, but also the patient, if they have a lesion perhaps in the MLF, they will have a large exotropia. And I will show you two examples of this. But here you see that this is a patient who had a large tumor in the fourth ventricle. That tumor is present right here. And she had resection of this tumor. And this is, again, this is the back of the pons, the area where the PPRF lives. And there is, where the yellow arrow is showing you, some edema in the PPRF and some damage to the PPRF from the surgery. And so this patient now presented to me with a complete inability to look to the side. So she has absolutely normal horizontal gaze, vertical movements, vertical movements, up and down gaze, completely normal. But now she's going to try to look to each side. And when she tries to look to each side, she's trying to do something. And so she just moves her eyes up and down. She keeps moving them up and down because she has a complete inability to move up and down, to move side to side. But you can see that she has preserved convergence. She has preserved adduction. So this is not a nuclear sixth, because if she had a nuclear sixth, her abduction and adduction, the absence of abduction might also give her a large angle exotropia, as you might see in this patient here who has bilateral internuclear ophthalmoplegia. This was mentioned previously as another supranuclear, it's like an internuclear gaze disorder, a problem in which this patient had a stroke involving an area similar to the patient I just showed you, but he has a complete lack of adduction of each eye with preservation of abduction, another supranuclear or infranuclear gaze disorder that in this case is producing a fairly large angle exotropia. So looking back to the first patient I showed you, what did we learn from that case? She probably had a midbrain infarction, a combination of a bilateral nuclear third nerve lesion as well as a supranuclear gaze palsy. It may have spared the medial recti subnuclei bilaterally, as well as the MLF, but these are complicated patients. And that's one of the messages I want to leave you with. Think about supranuclear gaze disorders and think about the various parts of the brain where they can occur. Classically, midbrain lesions cause vertical gaze disorders. Pontine lesions cause horizontal gaze disorders. Vestibular lesions cause vertical gaze or cyclovertical disorders with nystagmus. But those rules break down because patients don't read the book. Their tumors can compress multiple structures. You can mimic infranuclear and nuclear problems, and appropriate testing can help to sort out the causes. I thank you very much for your attention.
Thank you for an amazing talk, as was expected from you, Dr. Prem. Thank you so much. Any question, Dr. Jyoti?
Yeah, one question. How do we assess a patient with oculomotor apraxia? We see a lot of children with having that. Something that you want to, just mention what it is for the sake of the students, and how do we assess them?
Absolutely. For the sake of time, I didn't mention that, but oculomotor apraxia, especially in children, patients will use head thrust maneuvers. They will turn their head and then their eyes will follow in order to try to get their gaze to go into different positions. This there can be acquired oculomotor apraxia as well that has been described after thoracic aortic aneurysm surgery. And so it generally does not present anew in adults except in those isolated cases where patients have that history. And again, in children, I look for head thrust maneuvers and the ability that patients learn to overcome their problem that way.
And just end with some few points for the students about what are the specific things they should look when they look at supranuclear disorders. What are the points to differentiate them from the nuclear ones?
Absolutely. So again, in supranuclear disorders, the ductions are generally full. There is generally not a limitation of duction in any particular direction. And it is important that if you see a duction limitation, to always do oculocephalic maneuvers to try to overcome that apparent duction abnormality. Because if that oculocephalic maneuver makes the eyes move better than just asking the patient to move their eyes with either pursuit or saccade, that is one of your big clues for a supranuclear gaze disturbance. And then brainstem cerebellar lesions are often accompanied by either nystagmus, square wave jerks, or other cerebellar signs such as tremor or ataxia, or those other visual signs I indicated, like a disruption of the vertical. So it's important to ask the questions about these other signs to see if they are present.
Okay, thank you very much.
Thank
Dr. Jyoti, thank you very much, Dr. Prem. I think thanks a lot for your presence today.